What I'm talking about is the cognitive work that we do in seeing patients, right? That generates procedures, it generates pathology, it generates anesthesia, it generates radiology, it generates pharmacy, it generates infusions. But it's almost like a pyramid. And what we're faced with going forward is what happens when there's less need for endoscopy. A lot of those ancillaries start to contract.
Dr. Scott Ketover, President and CEO of MNGI, Minnesota Gastroenterology. I'm so honored to have you on the Scope Forward show. I want to first warmly welcome you.
Thank you, Praveen. I'm happy to be here. You and I have known each other for a while and have crossed paths, and along with several others, to talk about the future of GI and where we think the practice of GI medicine is going. So I'm very happy to participate and answer your questions. And as much as information as I can provide, I'm also interested in, I watch a lot of the videos that you produce so that I can learn something new along the way.
I'm looking forward to this conversation. Since the last time we did an interview, which was for the Scope Forward book, the GI landscape has changed dramatically. So I want to ask you, what do you think?
Sure. Well, no one could have predicted COVID or a pandemic or lockdowns or what happened since we talked pre-COVID. And that has had a dramatic impact in a couple of areas. One, it proved for gastroenterologists, particularly those in independent practice, how vulnerable we are in terms of our revenue. You know, a year ago at the height of the lockdowns, there was essentially very little ambulatory endoscopy going on, which is, at least from a financial viewpoint, the lifeblood of today's current GI practices. And so it was a quick awakening to think that revenue could be down significantly for the year, which in the independent world drops right to the personal incomes of the physicians. For physicians in an employed setting, I'm sure they were challenged because their entire institution was challenged. So COVID was a rude awakening, but it also caused us to step back and say, so our vulnerabilities, which we had talked about theoretically in the past, are now real. If we can't see patients face to face, what do we do? How do we provide care? How do we take care of our patients? How do we take care of our employees? How do we take care of ourselves?
Mm-hmm. And we'll talk more about that, because pre-COVID, you had mentioned that, diversify from colonoscopy, and you got to focus on the entire GI tract. But I'll come to that in a bit. First, I want to talk about private equity in gastroenterology. The last I've heard, and this is as of this week, that almost 50% of DHPA, or the Digestive Health Physicians Association members, they're in some form of PE umbrella. Is that accurate? Did you expect to see this rate of acceleration?
I actually did expect it, and that's because it's a very attractive model for both small and large practices. Large practices, of course, have the advantage of being the platform to which you can add on other practices and grow that medical services organization. So I'm not surprised by the attractiveness of these relationships, and I see certainly reasons why many practices would do it.
Going back to pre-COVID, you told me that you'd hired Deloitte, and MNGI evaluated private equity and decided not to go for it. Now, given the market changes, are you staying with your decision, or are you reconsidering that decision?
First of all, we are staying with our decision, but I'm not sure that the change in the market had a big influence on the decision one way or the other. I've thought for a long time that there are essentially three reasons why a practice would want a private equity partner. One is certainly to have the business acumen of those who are not clinicians, but know how to help develop, run, and grow businesses. And I think that's an important asset for a lot of practices. If they don't have it internally or don't have it through other means, that private equity can provide that. I also think it's a great opportunity for practices that want an infusion of capital to spur their growth, whether it's in hard assets or it's just growing their geographic footprint and their importance in their communities. And lastly, I think the reason is for physicians who are in independent practice, we recognize that our asset is us. And so when we stop practice and walk away, that asset vaporizes. And unlike a lot of private businesses where you can build a business for decades, and then when it's time to retire, you have an asset that you can transfer to somebody else. You can't transfer your professional work to someone else when you stop working. And so for a lot of physicians, private equity is an opportunity to take that sort of illiquid asset of themselves and turn part of it into a liquid asset and take money off the table to invest in other things in their life. Mm-hmm. So I think when practices look at private equity, they should really be thinking about, what motivates them? Is it the dollars? Is it the business acumen? Is it the MSO and its impact on the community? And ultimately how it affects patient care?
So from a growth perspective, what is the growth strategy for MNGI from this point?
I'm glad you asked that question because our strategic plan includes growing our geographically as well as in service lines. And we're looking at opportunities right now at expanding outside of the Twin Cities metro area in terms of both developing facilities and hiring physicians to be MNGI physicians working in places that are not within the umbrella of commuting distance to Minneapolis and St. Paul. It's an interesting question for us to ask ourselves why. How important is it to do that, to expand that footprint? Does it solidify our place in our current marketplace? Does it give us more leverage with payers? Does it help or does it help us defend against hospitals who might think that they should hire their own GI employed physicians? And we're wrestling with that now because it's not easy to duplicate what you have, let's say 90 or 120 miles away from where you sit, where it's not a place that is affiliated or easy to get to.
Coming to, a couple of key areas why people consolidate or practices or businesses consolidate in healthcare or in private practice is that leverage that you get with insurance companies and then with health systems or local hospitals. How have you managed to negotiate with insurances and the health systems in your region?
Yeah, good point as well. So that type of leverage I've come to accept is what I would think of as negative leverage. And the provider groups, the leverage really is saying we won't join that network, or we'll leave that network, or we'll leave that hospital system unless we can negotiate a contract that we think is favorable to us. But it's sort of a binary decision, right? You're either in the network or in the hospital system environment, or you're not. If you leave, you certainly don't do anything to enhance the care within those systems you're trying to negotiate with. However, it's been really the biggest and major lever that independent practice has when negotiating with payers. I'm starting to appreciate that even at our size, with 85 gastroenterologists and 900 employees and 9 locations, et cetera, as big as we are, we're dwarfed by the payers and the hospital systems. And even the PE-backed MSOs, 300, 500, 1,000 physicians, yes, that's a lot of leverage in staying in a network or leaving a network, but it doesn't yet prove what the positive side of that leverage is. And I think that's really the future of where we're going, is to see how do we make our leverage positive, mean we're bringing more value to those we have relationships with, and we're steering what happens in value-based care rather than reacting to it.
Mm-hmm. Do you think our dependence on insurance systems will reduce over time, or will stay the same or increase?
GI still remains a largely referral-based practice. In most areas, gastroenterologists are dependent upon primary care referrals for patients. We have a strategy trying to increase our self-referred or independent patients and families that come to see us. But I think insurance and third-party payers will still have a large role. There's some talk now, about expanding Medicare down to, age 60 or potentially age 55, what impact that would have. It would certainly increase the percentage of government pay patients that we see and change the payer mix. But I don't think we're going to do away with commercial insurance companies in the near future, and certainly not in my career.
Question is, if you consider digital health, about $20 billion plus were raised during the COVID period in 2020, and over 600 plus deals. The way I look at it is these companies seem to be servicing the same patient or the same consumer that GI and other specialties are servicing, but in a completely different model. So they seem to be figuring out newer business models and newer ways, while GI and other practices seem to want to do more of what they've done in the past. Am I thinking this correctly, or am I completely wrong?
No, I think you're on the right track. I think that we've been very fortunate for 2 decades that endoscopy procedures have driven the revenue side of independent GI practice. So procedures themselves need to be done obviously face-to-face or in person, but there's threats to that volume. Certainly as technology improves, different screening methods as opposed to screening colonoscopy, there will likely be more and more screening methods that help to stratify risk for individual patients and families, and that will have a negative impact on screening colonoscopy volume. I often talk with my partners about the fact that if you look at just what we are compensated for in our professional services, it's way less than half of our total compensation. So from a financial viewpoint, the work of a gastroenterologist is compensated by the ancillaries that the professional services generate. Whether that's, what I'm talking about is the cognitive work that we do in seeing patients, right? That generates procedures, it generates pathology, it generates anesthesia, it generates radiology, it generates pharmacy, it generates infusions. But it's almost like a pyramid. And what we're faced with going forward is what happens when there's less need for endoscopy. A lot of those ancillaries start to contract. And so for the gastroenterologist today, the opportunity cost to move away from screening colonoscopy is still too high. And what I'm trying to help my practice plan for is let's not wait until that opportunity cost drops significantly to spur us into other areas. Let's think about how we can develop the future, anticipating that opportunity cost will come down.
Mm-hmm. You've mentioned in the past that the gastroenterologist must own the GI tract. So you must come up with programs that service the entire GI tract, and we must move away from colonoscopy. Can you share more?
Yeah, I started to think about this years ago, actually, when I started to do capsule endoscopy. And the given imaging pill cam, the original commercial name was M2A, capital M, number 2, capital A. And what that stood for was mouth to anus. And shortly after they came on the market, they realized that was not a consumer-friendly name to have on their product, so they switched away from M2A. But it often has made me think that, the GI tract, really, it starts at the tongue. And so when you swallow something, that's in the purview of the GI tract. And we should look at what we do, treating from, swallowing a bolus to the exit of the unused portions of what we've swallowed, and see that GI tract is really our entire domain. But again, the opportunity cost to move resources away from procedures is still too high for most people to invest. We've tried in our practice, and I think have been successful in looking at creating centers of excellence around non-colonoscopy issues. Advanced esophageal disease, inflammatory bowel disease, liver disease, functional and motility disorders, celiac disease. these are treating more of the patient than just the endoscopic portion. And I think we really need to look at that. We really need to figure out ways that we can interface better with ENT or pulmonary medicine, or even urology and colorectal surgery when we're looking at pelvic floor issues. But again, I think what is delaying that movement is really the opportunity cost to move away from the highly reimbursed endoscopy procedures.
So how is that shift going to happen, Dr. Ketover? Because there's so much dependence on the reimbursement, and we don't see it quickly going away. It's steadily going away. So there is no drive to take immediate action. Everyone keeps thinking that it is on the horizon, and maybe that horizon is really far out. Maybe it is not at all. But then, when do you think this shift will happen to doing these other aspects of GI care, which obviously comes at an opportunity cost?
Sure. And the counter argument is, right, on a population basis, there are too few gastroenterologists in the nation, right? We need more gastroenterologists than we have today. And so you would think that gives us more leverage, right? There's more cancer screening to be done. There's more endoscopic treatment we can do. There's more infusible drugs. So you would think we would be sitting in a pretty good seat in terms of leverage of our clinical skill. But we're competing with behemoths that have billions of dollars of assets and are really looking at, while they talk a lot about looking at quality and outcomes, they're really looking at the cost of care. How do we deliver what is assumed to be reasonably high quality care nationwide? How do we just deliver that to the population? So I think to get gastroenterologists there, we're going to have to come up with a new way for us to practice our skills, our cognitive skills of patient care, that separates it from the fee-for-service piecemeal revenue production. And so my personal thought on this is that the winner in all of this is data, that data is king. And we see this happening even practically today. There are now 17 companies around the world that are creating COVID-19 vaccination passports, apps for your smartphone. The explosion of electronic and digital data is also happening in medicine, but clinicians haven't felt it yet. And I think that there's an opportunity for gastroenterologists, whether they're already in MSOs or private equity-backed practices, to still integrate in another fashion around data, around having a huge common database that is controlled by the gastroenterologists and their entities that can look into clinical questions and really prove where cost effectiveness can be achieved and where clinical benefit is really present.
Mm-hmm. Do you have any digital health initiatives going on at MNGI?
Well, certainly we're deeply involved in telehealth. We have used our EHR for 2 decades, but I see that this is really going to come from the outside. I don't think the EHR vendors are going to move into the database management of clinical issues quick enough. I do think there will be third parties that come together. And if gastroenterologists don't pool their resources to do this, then I fear that the vacuum will be filled by the large companies that already exist in the tech space. And then we will just become another sort of cog in that wheel. We are generating the data. We are doing the patient care. And yet that data is locked currently in our EHRs. We can't really mine it for use to help patients to move the ball forward. And we need to find a way to do it ourselves. So when you ask if MNGI is currently doing that, we're very much looking into the opportunity to do that and talking to those who could help us. But it's not just going to be MNGI. It has to be MNGI and tens of other GI practices, whether they're with private equity or not, independent private equity, even hospital systems. We have to put together the network that allows a one database around GI conditions to lead this change.
I want to ask another question on digital health. Let's say you have IBS patients. Now you are treating them in a certain way, right now. And one of the things that I've heard you say earlier is that the way you can address IBS is maybe in partnership with, someone with sleep medicine or psychotherapy, or or cognitive behavior therapy, and addressing the condition differently. So that's on one side with you as a GI practice. But on the other side are several startups that are helping the very same patients through digital means. Like, so there is really no physician. It is through an app, and there is an artificial intelligence algorithm probably going on. And there are people, yes, maybe there are clinicians, but they're sitting maybe in some other part of the world, and they're creating this. So the solution is one to many. Have you thought of how competition for you will evolve in this light, or do you not worry about that at all at the current stage?
Well, it is a concern. And with respect to IBS, I'm actually an investor in a company that provides food, meals for IBS to guide them through the FODMAP diet and to get patients to a better place. But that's still a one-on-one, right? It's a company and a patient, and it's a subscription model. But I think you're right. With artificial intelligence and databases of what works clinically, patients will seek that out. Long before Western medicine accepted things like acupuncture, patients were already there. Right? They went for acupuncture, they went for hypnosis therapy, they went for different kinds of massage therapy and things that years ago we used to consider on the sort of the loose edge of actual clinical help, but patients found relief. And that will continue to happen. I think the question you're focusing on is, well, there are entities out there that can develop electronic means to bring that help into the patient's hand, into their smartphone, and bypass the physician altogether. And how will GI practice cope with that? It will likely mean that we will focus more on the disease entities that require more of a direct relationship with the patient, driven through evidence-based medicine.
This whole COVID period has been a very reflective time for many, and especially in healthcare. And again, I've heard you say many times in the past that healthcare is a higher calling. And I'm sure, like a lot of people, a lot of doctors in the space, you must have thought and reflected on why this is upon us, and how medicine could have been different, and how a physician's role might evolve or must evolve. But overall, I want to ask you, did your thoughts on the future of GI take a different shape during this period? And again, maybe at a personal level, your own role, going forward on what you'd like to do based on how GI care might evolve.
Yes, first of all, it has changed. My thinking and feeling has changed. But pre-pandemic, right? If I turned on Netflix and watched the movie Contagion, it was science fiction, and yet there were people in the medical and scientific field who believed that could happen. And most of us went about our lives thinking, nah, not in my lifetime, that won't happen. That's something that's happened in the past, and we can protect against that. What the pandemic taught us was that in our connected world, which Tom Friedman talked about well over a decade ago, that something that happens literally on the other side of the world can be in your community in less than 24 hours. And so the rapidity with which these things can happen is phenomenal. And we should, as we come through this pandemic and hopefully, sometime this year, begin to enjoy our social lives and get out of our homes and out of our masks, et cetera, not think that we're done. that I'm now a believer that there will be another one and another one and another one, particularly as we become closer and closer to individuals around the planet. That has shifted my thinking somewhat about patient care to try and think more broadly about populations and how we improve disease management with populations, which still filters down to the individual one-on-one relationship. But how do we structure our healthcare delivery so that we can improve the health and well-being of populations at the same time?
Yeah. What does the future of GI look like from this point?
Short term looks quite good, actually. I think that there is still a lot of reason for physicians, practices, hospitals to invest in endoscopic units into procedures. I think that we are on the cusp of seeing really good therapeutics for diseases we hadn't had anything in the past. Now we're looking at treating NASH and fibrotic liver disease with drugs, whether they be infusibles or oral drugs. So as the practice of GI keeps moving forward, in the short term, I think there will remain a large emphasis on procedures, and I think that's appropriate. But I also think we have to step back and say, how do we do our cognitive work better? How do we devote time to developing the programs that really enhance somebody's life as opposed to just treat them endoscopically from a surgical perspective? Those are tough questions, but I think the future of GI remains bright because, as I've said, if it goes in your mouth, it's in our domain, and we should accept that and look for ways to keep people healthy.
With that future in mind, what actions must people take, must gastroenterologists take today? What is the foundation that must be laid today in order to make such a future happen, where GI care can mean much more than endoscopies, but everything from the mouth to the anus?
So we're still in a siloed world. My practice, your practice, this hospital, this system, right? We still have a great deal of silos in the delivery of GI care. We've been traditionally concerned and afraid to share our data with other silos because it either weakens us or strengthens them. And I think we need to get beyond that. I think we need to look at these individual silos and say, how do we create the network of these silos that makes all of them better? And I'm really focused on data. I think there will be, and is coming soon, the opportunity to network practices, whether they're independent, employed, backed by private equity, to network the data collection, the aggregation, the analysis, and the clinical use of data in a way that benefits everybody, all of the practices, all of the systems, and most importantly, the patients.
Thank you very much, Dr. Ketover. Is there anything else that you wanted to share that I did not ask?
No, not specifically that you didn't ask, but I will say that I think you're doing a phenomenal job with, certainly the follow-up to your book, as well as all of these interviews and keeping us informed. And I think I learn way more than I give. So this is one of those areas where you've helped me be a taker as much as a giver. So thank you.
I'm so glad to hear that. Thank you so much for saying so. Dr. Ketover, this has been amazing. And I'm sure the GI community will learn a lot from this interview. Again, thank you very much once again for doing this interview.
Thank you as well.